thank you very much for joining us today for another episode of our Pearls monthly lecture series. For those who are new to the program, PEARLS stands for POCUS for Emergency and Acute Care in Resource-Limited Settings. We are a non-profit organization entirely run by volunteers, and we aim to provide free POCUS training to doctors all over the world. And it's our great pleasure today to have Dr. Greg Stiller, an emergency medicine physician currently based in Colorado, USA. He has an impressive range of expertise, including wilderness medicine, military medicine, and flight medicine, and has worked in multiple austere settings, including the Everest Base Camp, Kilimanjaro, the Antarctica, the Andes, and many more. So please join me and welcome Dr. Greg Stiller. And before we start off the lecture, I would let Greg talk a little bit about himself, about his training and his experience, and how he got to be involved in so many exciting adventures over the years.
All right. Hi, everyone. Thank you, Long. So I started off as an emergency medicine physician, and after my training, I did a fellowship in ultrasound, as well as emergency medical services, and then subsequently I did a wilderness medicine fellowship. And from an early part of my career, I started doing a lot of travel medicine as well as search and rescue in the mountains of the Rocky Mountains. And over the years, it's evolved and it's included multiple different places, such as Long was saying, and a diverse range. I've worked from jungles to deserts to high mountain places. And overall, I would say the high mountains have been the most challenging overall, specifically in the application of medicine. And we're going to discuss today a lot of those limitations and things you have to adapt for. And that's going to be the primary focus of today's lecture. I'm not going to go into a lot of detail specifically on scanning techniques or anything along that line. It's going to be more the actual logistics of doing this. And a lot of the photos you will notice are going to be file open source from the internet because we were limited in being able to take photos. So we have a couple from people's cameras, but our ultrasound wasn't able to load to the internet. So we weren't allowed to, we weren't able to upload, and we didn't have a thumb drive that was functional. So we'll talk more about that as we go.
Awesome. Thank you very much, Greg. I think we can have many people here in the attendees, so I think we can start the lecture.
Okay. So we're going to speak today about POCUS in high altitudes and more austere locations, and we'll get started. So first thing is to understand where we're going to go. And I worked at Everest ER for the season as a Western physician. There's always two Nepalese physicians and a Western physician working at Everest Base Camp. And this is established through the Himalayan Rescue Association, which is a nonprofit volunteer organization that's been around since 1973. And the primary goal is to bring remote medicine, primarily to Nepalese, as well as to provide the service to those that are visiting those areas. There are three different areas that you work in. There's Manang in Annapurna, Farishay, and Everest Base Camp, which are both in the Everest region. And you have to do one of Manang or Farishay before you work at Everest Base Camp. And this gives people a chance to get the skills in terms of working in the mountains and dealing with some of the challenges. Manang and Farishay both have fixed facilities with walls and electricity most of the time, as well as some water and often hot water. Everest is a little different, as we're going to see. The HRA charges a minimal amount for trekkers to visit the clinic, and this allows them to treat all the native Nepalese for no cost. And this has really increased the level of medical care, especially for people that live in the actual region. And we'll see people who are up in the Everest region more than half the year. So it's often an interesting mix of emergency medicine and chronic medical problems that come in. So we'll start with Everest Base Camp, and picture to the right is as you're approaching the base camp, and to the left you see all the little yellow spots are actually the camp and the tents. To the right is the Khumbu ice field, and going up higher up and to the right goes up towards Everest. When you're actually at base camp, you can't see the top of Everest. You're in the shadow. And the Everest ER is located at 17,600 feet or 5,364 meters. So even at base camp, when you first get there, you're short of breath just walking from one area to the next. And it can take up to 30 minutes to get from one end of the camp to the other. So doing house calls in the middle of the night was sometimes pretty exhausting. And the way you get there is you'll fly into Lukla, which is a town that has the airfield where you can fly in from Kathmandu. And from there, you do generally a 9 to 12 day walk to get to Everest Base Camp. And it's a decent distance, but more importantly, that walk is designed to allow people to acclimatize. And it's important to understand this because it becomes a very large part of the pathology that we see at Everest Base Camp. Along the way of this hike are several places where they encourage people to stop and take a couple days to let their body catch up to the acclimatization. And this includes Namche as well as Fairshea. And there's a couple others that are added into people that are having difficulty getting up to the altitude. And this becomes a problem later because we find a lot of people show up and have travel delays or weather delays, and they rush to get up and skip the acclimatization stops, and then we see them because they're getting sick. So if you're going to plan a trip out to the Himalayas, you want to make sure that you take your time and have time for your body to catch up on the acclimatization. In addition, the only way to rapidly get off Everest Base Camp is helicopter evacuation, and that is for pay. So it's very difficult for anybody outside of Nepal to get out of the region unless they're able to pay for the helicopter or have travel insurance, which is a whole nother discussion. At night, the temperature is generally going to drop below freezing, and there's no running water. The water that we use in the camp is all hand carried. And if you see that white area of snow, that's the Khumbu ice field. And that's where the camp people will go over to actually get the water, dig under the ice, pull it out, and carry it all the way back up to the camp. So water is a sparse commodity. So we generally got a shower once a week, and a shower consists of 1 bucket of warm water that you can use in the tent to wash off your body as well as wash your clothes. All right. So this is the ER. And as you can see, it's fairly simple. It's a single tent right in the middle of the base camp. The tent's off to the right, and behind it is where we live. And up above us, you can see the mountains beginning quite quickly. And in that entire bowl behind us, we could regularly see avalanches coming down in the morning, which was quite a show. But obviously, we're in a safer location here. This entire area that you're looking at is on the Khumbu ice field. So if you dig through the gravel, you will actually hit ice. And this becomes relevant during the season because in the beginning of season, the Khumbu ice field is full and everything is stable. But as time goes by, things start to melt. So you'll develop holes in the bottom of your tent. You'll develop areas that start falling off to the side. And the ground becomes very unstable as time goes by. And that changes who sees us because we see more injuries. The ER has no x-rays. Obviously, there's no imaging form here at all. We have an EKG that's old school, and we have an ultrasound present. The ultrasound tends to vary by year, and it depends what's able to be obtained either voluntarily from a company donating for the season, or there's an ultrasound up there. However, as you'll see, the ultrasound that was present is no longer used, and we're going to explain why. It's one of the limitations we experience. There's no nursing or other staff. There are 3 physicians, generally 2 from Nepal and 1 Western doctor, and the combination is quite helpful. The majority of patients we will see are going to be the Nepalese, whether it is porters, guides, a lot of the people that are working in the camps, whether they're cooks, whether they're setting up the camp at the beginning, but they're the majority of the people we see. And then on top of that, we see an international crowd of climbers and trekkers coming through Everest Base Camp as a destination or as the base camp to proceed higher up the mountain. There are no labs. We do have a urine dip and a pregnancy test, and we have IV fluids. However, they're only available later in the day because they're frozen solid every morning. We have all kinds of insulated coolers and different ways of trying to keep things from freezing, but generally every now and anything being liquid and everything freezes over. So it's important to keep in mind when you're managing our patients. So this is the inside of the tent. The back row you can see are a bunch of drawers that contain all of our medications. We have 2 beds in the front, which is where we take care of our patients, and this is the extent. We have 1 bare light bulb in the middle up top, so lighting is a little limited at night and makes it difficult. But the biggest thing is there's no temperature control. So during the day, a lot of days it's still freezing, below freezing temperature-wise, which makes it really difficult in terms of your patient exposure. We have that fine line of exposing our patients to get a full look at them versus causing hypothermia. There's no heat control whatsoever in this tent, although during the days it can be a pleasant temperature. A lot of times we show up to work in the morning dressed like I am in the lower corner with a full puffy down and full gloves. A lot of times your face is covered with a buff, the covering, because of the amount of dust that blows through. So difficult place to get our patients fully exposed and get a look at them, as well as doing ultrasound. Other limitations we experience, as you can see, hands get extremely cold. The bottom right picture is a picture showing some early frostbite. This is before they've developed blisters. This is quite acute. And this is in the clinic. So you look at our ultrasound machines and you think, are we better off with the roller ball and buttons? Are we better off with the touch screen? And with limitations with both. With the buttons, oftentimes your fingers are so cold you can't touch the smaller keys without hitting other keys because it's hard to get your sense of feel. With the touch screen, sometimes I couldn't get it to actually register my fingers. So a lot of times when we were doing ultrasounds, we would have to have one person doing the scan and the other person would be there with gloves on, taking them off in between to be able to work the dials or the touch screen. So first major limitation there is your fine motor skills and your ability to actually do the scan. In terms of actually doing them on the scanning side, not too difficult because you're using more gross function, but the screens and the knobology was difficult. And this is the second big limitation. We had lots of ultrasound gel in the classic size containers on the left, and then we found after the first morning that they were frozen solid. And they would sometimes thaw during the course of the day. Oftentimes they'd still be frozen when night came again, and we couldn't do anything with it. So people would have the suggestion, well, you take the bottle into your sleeping bag and you'll keep it warm. But at night when it gets really cold, the only thing you want in the sleeping bag is a hot water bottle to keep you warm, let alone having a cold bottle that leaves you shaking at night. So what we discovered was having small packets, such as the surgical lubricants on the right, was a lot more effective because we could get up in the morning and we would stuff our pockets full of lubricant, and that way it would thaw and stay melted during the day, and that was what we wound up using to be functional. So smaller volumes was much more appropriate to what we were doing. Another consideration, and the major consideration, was the electricity at camp. So the electricity during the day is all solar. So when we had snow or cloudy days, or just sitting in the clouds, there was no electricity during the day, no active electricity. We had a few hours of generators at night. However, this is mainly resolved for the camps to function. So at night, people would come in, they'd have dinner, they'd be cooking. The tourists and the climbers would come through and they would be using energy to recharge, which is the fundamental of the economy of Mount Everest. So for us, this meant we sometimes could get a couple hours of charging time. As a result, we have no patient monitors because the monitors take up too much charge and we can't support them. We have the single light bulb, as we talked about. We often worked with headlamps. It was a lot more functional. and our ultrasounds were limited. So we had a nice sized ultrasound unit that we were unable to use because the batteries could not be charged. And if we could get part of a charge on them, they wouldn't stay charged. So we wound up using a lot smaller units so that we could keep them charged. And we would do basically rotating batteries where we would charge one for 1 to 2 days till we had a full charge. We'd carry one on us that we were using as the active battery, and then we had a third one in reserve that we put into the circle to keep our ultrasound charged. It makes it quite a challenge to keep thinking about the battery options that are going on. And then we had this intermittent internet service, which at times was very good and at times would go out. And subsequently, we weren't able to upload any of our photos to share if we did need help. If anybody wanted to get a consult or discuss it further, we'd have to take a picture on a cell phone to be able to send it out because the machines just would not be supported by the internet. So you'll see on this talk, a lot of the images are filed open source off the internet to illustrate, but aren't original films. And I'll point out ones that are original. This is the camp after a night of snow. And obviously you're rolling out of bed. This is actually full daylight. So we're already into time to be at clinic. And you can imagine it's a little hard to roll out of bed to go to work when it's the same cold temperature, except for you don't have your sleeping bag with you. So let's talk about the perfect ultrasound that we would dream about while we were at Everest Base Camp would be small and lightweight so we could bring it back and forth during the end and beginning of season. You don't want to leave a lot of equipment up there between seasons. One, there's a kind of temperature swings. Two, there's not a lot of secure areas. Three, you are exposing it to a lot of dust. The glacier tends to scrape rocks, so there's a fine dust all over the place as a result of the glacier coming down off the mountains. So things to keep in mind with the ultrasound. We were able at times to get an ultrasound brought to and from lower down by helicopter, but it does count as a piece of luggage, and you have to work that to be able to get that accessible. We'd like one that would be big enough to have buttons that you could feel, or a touch screen that could be usable with really cold hands. Obviously, we'd like to be able to do multiple different scans. We had used small part probe all the way up to a phased array for multiple different scans with our current. And then we would see people come through with the newer generations without saying the makers of ultrasounds, but the single transducer ultrasounds, which is really a terrific development, sacrificing the size of the screen, but allowing us to do multiple scans with one handheld unit. And obviously, it's a lot more portable. The downside of those types of units is the durability. We had to contend with impacts. So when things are moved to and from, we have a lot of drops. A lot of different people are carrying the load. So whether it's porters who aren't always conscious of how delicate these machines can be, have to deal with the cold and obviously getting wet. And then as we discussed earlier, battery charging was a major problem with keeping things stored. Ideally, having some internal storage, it would be great to get a library of images taken. And when people came up there focused on ultrasound, there was a better chance of being able to store images. Going there as a general physician to work and without the focus on ultrasound study, a lot of people don't really think about that ability to store the images. So patient-wise, so what do we do up there? We saw over 600 patient encounters over the 3 months. So fairly busy, enough to keep us going. The most common conditions include acute mountain sickness, high altitude pulmonary edema, high altitude cerebral edema, trauma of all varieties. In the beginning of the season, we see a ton of minor traumas, hand traumas from setting up camp. And then we get into bigger traumas as people start moving up through the ice field and up onto the mountain. And Everest isn't the only mountain that people are climbing from Everest Base Camp. There's also Lhotse and a couple other mountains directly surrounding us where people will come and visit and then head up. A lot of upper respiratory symptoms develop. One, there's a lot of close quarters living. The sharing tents where people go to eat are all combined. So once one virus gets into town, it spreads throughout. And we'd see a lot of abdominal pain, nausea, and vomiting, and diarrhea. Infectious, whether it's from bad food, same thing, poor food preparation. Sometimes the food is carried in. So people would joke about if you think you're eating fresh chicken and you didn't see a helicopter come, you're probably going to get sick. And so you have to keep in mind that and be careful. By the end of the couple months out there, I pretty much could eat everything. But as in any country that you visit, you have to realize that you don't have the native flora and fauna in your gut. So you have to be a little careful at the beginning and ease your way in. But this figured in largely into a lot of the patients we saw. On the right side, that's fair shape. That's the last medical before you get up to Everest Base Camp. And they actually have walls and buildings. And as you can see, they have the pressure, the PAC on the floor there for altitude treatment. They're our primary backup in our sister clinic when you're at Everest Base Camp. So if we ran out of medications or they did, we would call each other and shuttle those between the two of us. And it's about a day walking for somebody who's well acclimatized. Otherwise, it's usually a helicopter to get back and forth. So I want to talk briefly about shortness of breath and the differential diagnosis so we can understand the value of ultrasound in this setting. Our primary 3 indications for shortness of breath and cough were high altitude pulmonary edema, upper respiratory infections, and Kumbu cough. And for those of you who aren't familiar with Kumbu cough, it's a dry, hacking cough that's felt to be more inflammatory than actually infectious. But it's a combination of different factors. And once somebody gets Kumbu cough up at Everest Base Camp, they generally keep it the entire time they're there until they go back down to lower altitude. Why is this important? Well, if a lot of people are walking around the camp coughing, it makes it highly likely you're going to miss when something more worrisome comes in. And so HAPE is something we saw almost daily, high altitude pulmonary edema, but we also saw an occasional pneumonia. We saw congestive heart failure. We saw acute coronary syndrome once or twice, and we saw pulmonary emboli. And high altitude setting predisposes people to thromboembolic disease. So you have an increased chance of dealing with DVTs, deep venous thrombosis, and pulmonary emboli and other complications of clotting. So keep that in mind as we go forward. So here's a first case presentation. A 30-year-old male presents to Everest Base Camp with 1 day of shortness of breath on exertion and a cough. And this guy is a trekker. He's coming in just to get to Everest Base Camp, and then his plan was to go back down and to go to Chilap Pass. So he's got no medical history, he's got no medications, no allergies, but there's some additional history that is really relevant to this case. So number 1, he hiked in, but he had some weather delays on his flight in, and he skipped one of the acclimatization days, hoping to make up time to get up to us. 2, the onset of his dyspnea was slow, kind of insidious and gradual, but he was the strongest climber in his group. And then a day before he got to Everest Base Camp, he started falling behind people. And people kind of noticed this, but didn't think much about it. That's an important distinguisher in terms of developing this cough. However, the complicating is the last tea house he stayed in, he said that everybody was coughing and sick. So now we have a lot of history that's kind of mixing together. His physical exam, he's got crackles bilaterally, or rales. His pulse ox is 62%, and he's tachypnic at 20. Now we see a pulse ox of 62% where I live in the United States. We are thinking about intubating this patient, and they're going to go to the ICU. But at Everest Base Camp, 60 to 70% is not uncommon. And the new people arriving at camp, we routinely would see people sitting in the 70 range. And when they were there a while, they'd get up into the 80s. And occasionally we'd see somebody in the low 90s, but that was rare. So we have to keep that in mind as we're evaluating these patients. So he's on the low side, but he's not as bad as it looks if I was coming from lowlands. So what do we do next? How do we differentiate this? We did an ultrasound. We'll see if this actually works. And I'm doing a little instruction for our junior physician. We had a fairly junior young doc, and we were teaching them ultrasound. And as you can see on the screen, it's pretty conclusive that we're seeing comet tails or curly bees, depending on how you call it. As you see, there's the pleura shooting off the comet tails between the ribs. The other thing, if you looked at the beginning, you could see the patient is, I'm going to see if we could do that one more time. You can see that every now and then that rib is in the middle, and then we move it into the middle, and then you'll see it moves out of the way again. And if you look, the patient's coughing pretty aggressively and is actually quite tachypnic if you look at the screen bouncing on it on his belly. We don't have side tables, so the ultrasound is either on the bed, on the patient, or one of us is holding it for the other. So what do we conclude this is? So this is high altitude pulmonary edema. And one of the hallmarks for us is it's pulmonary edema. So you're going to see curly bee lines or comet tails, however you call them. It's a non-cardiogenic edema. So how can I differentiate pulmonary edema in someone with HAPE from all the other etiologies? One of them is taking a look at their heart, if you have the expertise to see fluid status. But the biggest determinant is their history. So in a young guy with no symptoms such as a runny nose or fever or any infectious etiology, an insidious onset of cough with shortness of breath with exertion developing, and a ultrasound showing HAPE, we're pretty convinced that this guy's going to be HAPE. So as a result, he was treated with nifedipine, oxygen, and then we had him descend as soon as we could. Descent is the definitive management for high altitude pulmonary edema, and this gentleman did really well. So let's talk about another one. So here's another case presentation. This is a 45-year-old male who shows up. He says he has no past medical history. However, he's never seen a doctor. Okay, he lives in the region and there are no physicians. He doesn't take any medications. His altitude history is he's been at Everest Base Camp for 4 weeks working and has had some fairly strenuous activity up until about 4 days ago when he progressively got more and more short of breath. Of note, he noticed that what came up this year, and this is his yearly job, he comes up every year, he said everything was harder this year. It was harder to do things. So altitude history goes against high altitude pulmonary edema. We asked him about his cough. He says, it's wet. He says sometimes he spits out some pink sputum, but there's no purulent sputum along that. He hasn't had a fever. He has had no symptoms of upper respiratory infection. And on physical exam, you can notice down at his ankles, he's got some fairly significant edema. And we see edema at high altitude. A lot of people will develop edema at high altitude, but this is a level beyond. This is 3+ pitting edema. So this gentleman, we put the ultrasound on, and on the right, you can see we have our comet tails or bees, and so we have pulmonary edema. But his story wasn't making sense from a HAPE standpoint. And so you can see when we look at his heart, and I'm not an echocardiography, I'm an ER doc, so I have very limited in my skills relatively limited with echocardiology. But it's obvious that his right ventricle is distended and full. So we know right away this guy is different. He's got the pulmonary edema, so it makes it less likely that this is going to be a pulmonary embolus, okay, which is also in the differential for that ultrasound. But this does suggest that he could have congestive heart failure. So we take what we think is going to be the most likely, and we treat him as congestive heart failure. He gets aspirin, he gets nitroglycerin, not nitro for acute coronary, but more to help him with his breathing to lower his preload or his afterload. And then he got Lasix, and we evacuated him as soon as we could, which sometimes is a couple days. And he subsequently went down to Kathmandu where he had a full cardiac workup. He'd had a subacute cardiac event and was in congestive heart failure, for which they started him on meds. And we actually saw him at the end of season. He came back up and was working again. So a nice story for this gentleman. Let's go to another case. This is the inside of our camp with our primary medic, who's in the red jacket. He's also one of the only hoist operators for the helicopter, meaning this guy will go out on a rope and grab you off the side of a mountain. So he's pretty impressive, and he's a medic on top of it. And then on the right side, laying on the bed, is our latest patient. And he rolled into the camp around 2 in the morning in the dark. And with flashlights, we did a full assessment. And this gentleman was 38 years old, working in the Khumbu ice field, and he felt 20 feet with no loss of consciousness, but immediately complained of severe right lower extremity pain and some diffuse abdominal pain. His heart rate was 110. His vitals were otherwise stable, so he had good blood pressure. His chest was unremarkable on physical exam. His head, neck, chest, and extremities other than the right lower extremity looked normal. His belly was mild diffuse tenderness, wasn't focal, and his right lower extremity had an obvious deformity above the ankle, suggesting fracture. What's the relevance of ultrasound in this case? Well, obviously, we're going to do an EFAST, all right? But what do we do with it in the context of being days away from definitive care? Well, it becomes our basic triage of how important is it to get this guy out of here. The helicopters only run during the day. There are no flights after 6 o'clock by regulation. So at night, you're on your own. And you have to have reasons for the helicopters coming in. So if we have one coming in to drop off supplies, we can use that to get them out, unless we have a critical patient, at which point we can call them in medically. So for this gentleman, we did an EFAST, and the entire EFAST was negative. No pneumothorax, nothing around his heart, and no free fluid in his belly. His vital signs were stable with pain control. His tachycardia went away as soon as we got his pain adequately controlled. We splinted his leg, provided him with hypothermia prevention. As you saw, he was buried in sleeping bags, and pain control. And then we evacuated him a day later by helicopter, and he stayed in our ER, as you saw him laying on the bed, until the helicopter arrived. And his definitive diagnosis in Kathmandu is a right distal fibula and tibia fractures and no other internal injuries. So again, ultrasound pivotal in deciding how we manage this gentleman. This is another gentleman who came in. He was working going through the Khumbu ice field when a boulder cut loose, and it hit him in the side and supposedly threw him about 3 meters from the impact. So in significant mechanism of injury for this gentleman. He had no loss of consciousness, but he came in with severe lateral chest pain and difficulty breathing. And on exam, you can see he's bruising over his left flank, left ribs, and there's no crepitus on exam. There's no abdominal pain. His vitals show he's tachycardic at 105. He's got a SAT of 86% and a normal blood pressure. So we look at those vitals. He's slightly tachycardic, but he's obviously in pain, and his saturation is 86%, which for where we are is actually a good pulse ox. So next step, we do a full physical exam. We get him a little more comfortable, and we do our ultrasound. And in him as well, the EFAST was negative. Obviously, on the right, we're more focused on checking for pneumothorax. And you can see on the bottom, we used M mode and looked at his seashore sign. And felt pretty good that he did not have a pneumothorax. And this is a big, big deal for us because this gentleman's company did not want him to go out by helicopter. They wanted him to go out by foot or not to go at all and get back to work. So one, we're not going to keep this guy. He obviously or likely has multiple rib fractures with or without the pneumothorax. So we did pain management. We observed him for a day to get his pain under control, and then we evacuated him by ground, which means he's either walking or he's riding out by horse, which you can imagine with rib fractures is quite uncomfortable to get somebody out. And he subsequently, he had 3 rib fractures and a pulmonary contusion when he got down to town, and he did well. So a different way of thinking about it than we would in a typical city in terms of our triaging and how we manage and who we're holding. And a lot of it is dictated by ultrasound. All right, so get into a little different type. We had a 28-year-old male who presents with unilateral vision loss. He denies any pain, he denies any injury, and he denies any other symptoms other than the vision loss. He says he woke up and he saw floaters and then developed a persistent area of vision loss just off the center of his vision and in one eye only. So single eye takes out a lot of our differential and narrows it down, but the big ones that come up with this painless loss of vision would be things like a central retinal artery occlusion, more likely a retinal detachment, especially with his description of this kind of floating curtain that had us worried. Other things in the differential for unilateral vision loss, stroke, okay, definitely possible. And then there are a couple things unique that we'll talk about. But our biggest limitation is we try to do a fundoscopic exam, and doing a fundoscopic exam in the middle of the day in the light, we wound up putting a blanket over the two of us so we could look at his eye. We can't dilate him, so we have a limited assessment. So what do? Well, we did an ultrasound to exclude the retinal detachment. And so we got our ultrasound. It looks perfectly clean in terms of retinal detachment, which really helps. There's also no signs of a large vitreous hemorrhage. Okay, so I'm feeling pretty good about that. And we keep working and working and working at this fundoscopic exam. And finally, and the picture on the right is a file picture, but you can see he's got the little black spot. And our gentleman wound up having 3 of those black spots, including one right on the edge of his macula. And these are high altitude retinal hemorrhages. So occurrence that happens at altitude. Okay, there's no real explanation of why some people get it and some people don't. It's very common. So if you screen a lot of people, but the relevance is when it's right on the macula, which is why this gentleman developed the visual loss. And the management is going down to low altitude and time. So if he'd had the retinal detachment, we'd be kind of in a rush to get him out. If he had a vitreous hemorrhage, we'd have a whole different creature. But a high altitude retinal hemorrhage changes our entire plan for this gentleman. He actually did pretty well. He went down to lower altitude. He was tied to one of the expeditions, so he didn't leave completely. And at 2 weeks, he still was having partial vision loss. At 3 weeks, he was improving. And that's the last I got to talk to him. So you can see that in those cases, ultrasound was really the key determinant on how we managed the patient, how emergently, and when we had to get them out. In a setting where a helicopter can cost up to $1,000, which for a lot of people is absolutely determines they will not take the helicopter or refuse. Miscellaneous things that we dealt with a lot of leg pain and swelling. And you're hiking for days, so we saw tons of strains and sprains, but we also saw things like medial gastroc tears versus more worrisome would be DVT, especially with the increased risk of thromboembolic disease. So getting a decent ultrasound and was pivotal in making decisions. We had a lot of people who come in with areas of focal swelling, whether it was along the base of their neck, or their groin, or even perirectal. And so we had perirectal abscesses, we had a bunch of subcutaneous abscesses, and this often happens because of the change in sanitary habits when people are up there. As we talked about earlier, showers are hard to come by. And for the clients that are climbing, a lot more frequent. But for people that were on different level trips, their personal hygiene changes, they're wearing lots of layers of clothing. So we saw skin rashes and we'd see subcutaneous abscesses that we would drain. We also saw a lot of abdominal pain. Again, changes in diet for the people that are traveling. For the natives, it's very common to have gastritis as an underlying in the population, partially because of the diet. The diet's extremely spicy. And so at baseline, you have all these people coming in with epigastric pain, but we did occasionally have a gallbladder, including a cholecystitis or early cholecystitis that we had to get out quickly versus all the other people that we would treat and keep up there. So you can see the importance of discerning between what looks like a stomach versus a gallbladder. We didn't have anybody significant in terms of history for appendicitis. Fortunately, I don't know how many of you are doing routine appendicitis ultrasound, but we did do a couple quick scans on people up there. And fortunately, most of our climbing population tend to be pretty lean, which made the appendicitis workup a little easier. And then finally, procedures. We mentioned that our IV fluids freeze and would be thawed out by the end of the evening, but we did use IVs for medication administration. And oftentimes people come in very vasoconstricted because of the cold. So ultrasound-guided IVs was one of the ones we liked, as we talked about. Abscess drainages were also a significant part of our procedures. Looking at bones to try to discern whether we had fractures. And the relevance of this is the people that come up to work at the camps have a limited number of months that they make their income for the year. And if you tell somebody who comes in who hit their hand with a hammer and has an open wound, and you can't tell if there's a fracture, you need to go down, they're going to tell you they're not gonna. They don't want to go. So if you can get a reliable indication there's no fracture and treat the wound and keep them up there so they can work, you're doing them a big favor. But missing an open fracture in their hand could be the end of their career if they develop an osteomyelitis. So this was kind of a tricky one that we would try to use the ultrasound, get a good idea. If we were really worried, we'd use our sister clinic so they only had to go down for a couple days instead of losing their season. And so again, ultrasound really was a hero when it came to establishing our differential diagnoses, discerning between our top diagnoses and making our life a lot easier. And the last place that it turned out to really be significant is the picture is the Khumbu ice field. And it's hard to understand, but if you look in the foreground, there's little tiny black spots. That's a person. So you can understand how big this is. These are blocks of ice that are 10, 20 meters tall, where you see these blocks. So it's massive. And you go up that ice floe and up that little valley, and that's where Camp 1 is going up onto Everest. So one of the most common things we would get was people up at the higher camps, 1, 2, and 3, and then this obviously the push to the summit. We would get a phone call or basically radio call that would say, hey, this person's got shortness of breath and is having trouble, and we don't know what to do with them. So what do you do with that? Okay, you're doing telemedicine up at Everest. They would send the patient down to us, and a lot of times the patient would show up and say, I feel better. So is this high altitude pulmonary edema? And since they've come down 1,000 feet, 300 meters, is that why they're doing better? And we would do an ultrasound and we would still see the comet tails, the curly bees. So even though the patient felt better, we still have some remnant signs that would indicate this probably was a high altitude pulmonary edema. And that's probably the single greatest use for ultrasound when we were there, was making this diagnosis that is common, exceedingly dangerous if you don't have them descend and get them on oxygen, but also has these very nondescript symptoms that are easy to miss. So that is probably the largest use of ultrasound. By the time we finished the season, the 2 Nepalese doctors that I was working with who had very little ultrasound experience were pretty much experts in looking at chests and defining comet tails and beelines. And both of them I know were very, very excited to have learned that skill in this context. So that concludes our brief tour of Everest Base Camp and using POCUS at extreme altitude. And this is our helipad, which is right next to our working tent where we would evacuate all our patients. And I'd like to open it up for questions.